Okay, we're back on, and our next speaker is Dr. Stephen Glickel. Dr. Glickel is a clinical professor of orthopedic surgery here at NYU Langone Health, and Dr. Glickel, one of the former presidents of the American Society of Surgery of the Hand. We were very lucky to have him join our faculty a few years ago and combine our fellowships, and we're that much the better for it. Steve, if you're ready, please go ahead.
Okay, so I'm going to talk about radial nerve compression. Sorry. Okay, so this was a iteration of the talk which left out a couple of slides, but basically we're going to talk about anatomy, radial tunnel syndrome, posterior interosseous nerve syndrome, and Wartenberg's syndrome. So to briefly review radial nerve anatomy, in the upper arm, the radial nerve is posterior to the humerus and courses distally to the spiral groove. It penetrates the lateral intermuscular septum, and then it enters the anterior compartment approximately 10 centimeters proximal to the lateral epicondyle. In the brachium, it lies in the interval between the brachioradialis laterally and the brachialis medially, and it innervates the brachioradialis and the ECRL. It then divides into the superficial radial nerve and the posterior interosseous nerve, which course distally anterior to the radiocapitellar joint and lateral to the biceps tendon. The superficial radial nerve runs anteriorly and distally beneath the brachioradialis, and then the PIN proceeds distally and deep and medial to the ECRB. At the level of the radial neck, there's the leash of the recurrent radial artery, or the leash of Henry, which crosses the PIN and can be a source of compression. The PIN then goes deep to the superficial head of the supinator, beginning at the arcata froge. So the arcata froge is the fibrous proximal margin of the superficial head of the supinator. So in this dissected specimen, you can see the posterior interosseous nerve beneath the superficial head of the supinator, which has been divided here. And then the PIN passes distally from anterior to posterior in the interval between the superficial and deep heads of the supinator. It emerges distally and divides into branches innervating the superficial extensors. Sorry. So there are several sites of possible compression of the posterior interosseous nerve. The fibrous bands anterior to the radial head at the entrance of the radial tunnel, the radial recurrent vessels of the leash of Henry, the tendinous origin of the ECRB, the arcata froge, the proximal margin of the supinator, which is the most common site of compression, and then the distal edge of the supinator. So Jepson and Engber pointed out that it's possible to have more than one site of compression. So you can have a double entrapment at the proximal and distal supinator borders. So you need to explore the nerve throughout its course in the radial tunnel to achieve decompression. So radial tunnel syndrome is a compressive neuropathy of the posterior interosseous nerve in the proximal forearm, causing pain but no motor deficit. Interestingly, though, the posterior interosseous nerve palsy is a compressive neuropathy of the posterior interosseous nerve in the proximal forearm, causing a motor deficit but no pain. So the same nerve is compressed in two different syndromes. So to give you a historical perspective, Rolls and Maudsley in 1972 described what they called resistant tennis elbow in 38 elbows. They related this to repeated pronation, supination, and elbow extension. And on exam, the patients had pain with resisted long finger extension, with the elbow extended, and tenderness over the radial nerve in the proximal forearm. All of these patients responded to decompression, 33 of them through an anterior muscle splitting approach. And then Lister, Belsel, and Kleinert a few years later described 20 elbows. The clinical signs they described were pain with long finger extension, tenderness over the radial nerve in the proximal forearm, pain with resisted supination with the elbow extended, and they decompressed the nerve using a posterior brachioradialis splitting approach, and 19 out of the 20 patients had relief of symptoms. So the most common presentation of radial tunnel syndrome is that it is more common in the dominant arm, occurs in the 4th to 6th decade. Men and women are equally affected. It tends to have an insidious onset, and the cause is usually repetitive microtrauma rather than an episode of acute trauma. And 5% of patients who initially present with tennis elbow actually may have radial tunnel syndrome. So the etiology is felt to be repetitive activities involving forearm rotation and elbow extension with or without wrist flexion. In some patients, there's a dynamic component to the compression, and it also may be related to hypertrophy of the supinator muscle in laborers and athletes. So the typical symptoms are pain on the lateral aspect of the elbow and proximal forearm. Pain may radiate distally more than proximally, and pain is aching in character, and we'll get back to why that's important. The pain is also exacerbated by activity and usually relieved by rest, but it sometimes occurs at rest as well. It's also exacerbated by lifting objects with the wrist flexed and the forearm pronated. Night pain is common, and there may be weakness of grip, which is secondary to pain, not due to denervation. The clinical signs are tenderness over the supinator from the proximal to the distal end. So that's distal to the lateral epicondyle and the proximal forearm. And importantly, there's absence of tenderness of the lateral epicondyle unless there is coexistent lateral epicondylitis. The clinical signs are also pain with resisted extension of the long finger with the elbow extended, and pain with resisted forearm supination with the elbow extended. And the reason you extend the elbow is to eliminate the contribution of the biceps to supination. One of the ways you can help to diagnose radial tunnel syndrome is to do a diagnostic nerve block using local anesthetic. So if you inject local anesthetic just proximal to the radial tunnel, in the interval between the brachioradialis and brachialis, you should eliminate the symptoms. And one of the ways that you know you're in the right place is you often get an associated transient motor block. So the principal differential diagnosis of radial tunnel syndrome is lateral epicondylitis. And the principal way to distinguish between radial tunnel and lateral epicondylitis is the location of tenderness, i.e., there is not generally tenderness of the lateral epicondyle if the pain is from radial tunnel syndrome, and the converse is the case. The other ways, and I mentioned this previously, is the character of the pain. So the character of the pain in radial tunnel tends to be dull, whereas the character of the pain in lateral epicondylitis tends to be sharp. And it's also, one of the things that can help you distinguish is the response to injection, be it in the radial tunnel or near the radial tunnel or the lateral epicondyle. Electrodiagnostic studies are generally not useful in radial tunnel syndrome. Occasionally there may be EMG changes, i.e. denervation, particularly with resisted contraction of the supinator, and generally the nerve conduction studies are negative. In less than 10% of patients, you have positive EMG and nerve conduction studies, according to this published article. And so negative studies do not at all rule out a diagnosis of radial tunnel syndrome. So the question arises, how can a pure motor nerve cause pain? And Lister, Belsel, and Kleinert proposed that the PIN carries sensory afferent fibers from the radiocarpal, intercarpal, and carpometacarpal joints, and also carries afferent fibers from the muscles that it serves, and this may be the source of pain. So conservative treatment includes rest, long-arm splinting, anti-inflammatories, avoidance of provocative activities, therapy with extensive stretching and ultrasound, and steroid injection. If conservative treatment fails, the nerve needs to be decompressed, and there are 4 approaches that have been described. One is the anterior or modified Henry approach. Then there's the posterior Henry or Thompson approach, posterior approach through the brachioradialis ECR interval, and the transmuscular brachioradialis splitting approach, and we'll go through these briefly. So in the anterior approach, the incision is a curvilinear incision beginning approximately 6 centimeters proximal to the lateral epicondyle and 3 centimeters medial to the lateral supracondylar ridge. It extends distally between the biceps and brachioradialis. Then it crosses the antecubital fossa from lateral to medial, and it extends along the medial border of the mobile wad, and then curves laterally toward the ulnar border of the brachioradialis. So the cephalic vein and lateral antebrachial cutaneous nerve need to be identified and protected. The fascia is incised along the brachioradialis. The brachioradialis is retracted laterally, and the biceps and pronator are retracted medially, exposing the nerve. So proximally, as I mentioned before, the radial nerve is between the brachialis and the brachioradialis, and as it enters the forearm, there's a fibrous band over the PIN at the fibrous edge of the ECRB above the probe, which needs to be divided. The radial recurrent vessels are ligated. The arcade of Froge is exposed and incised longitudinally, and then you incise the superficial head of the supinator completely, exposing the compressed part of the posterior interosseous nerve. This is just another incision to the anterior approach, a slightly simpler incision, and you can see the decompressed nerve and the hyperemic markings on the surface of the nerve. So the first posterior approach is through the ECR-EDC interval, and it's easiest to identify that interval distally and then work proximally. So your incision starts distally and then extends proximally toward the lateral epicondyle. The forearm fascia is incised longitudinally. The interval between the ECRB and EDC is developed distally and dissected proximally, and then the supranator lies deep to the dissected muscles proximally. You identify the fibrous edge of the ECRB. These vascular clips are on the radiant recurrent vessels, which have been ligated. The arcade of Froge is incised, and the superficial head of the supranator is incised. Another approach is through the brachioradialis ECR interval. It's a 6 centimeter longitudinal incision beginning just proximal to the radial head and 3 centimeters lateral to the biceps tendon. You develop the interval between the brachioradialis and the ECRL. The PIN is identified, and the remainder of the procedure is the same as the other posterior approach. And then finally, the approach which I prefer is the transmuscular brachioradialis splitting approach, which can be done through a longitudinal or transverse incision. Longitudinal incision starts just proximal to the radial head and 3 centimeters lateral to the biceps tendon. The transverse incision is about 4 centimeters long over the mobile wad, just distal to the radial head. So the fascia of the brachioradialis is incised, and the fibers of the muscle are split longitudinally for about 5 centimeters until the fat deep to the muscle is exposed. And you dissect through the fat, you expose the posterior interosseous nerve, and the rest of the procedure is the same. These authors described a series of 49 elbows in 42 patients. There were 14 excellent, 18 good, but 8 fair and 9 poor results. 3/4 of the patients were improved after surgery, but 1/4 obviously weren't. 1/3 of the patients had persistent functional limitation, and 75% of the poor results were in workers' compensation patients. Jepson and Engbert reported 33 elbows using the brachioradialis splitting approach. They had 67% good or excellent results and 1/3 fair or poor results. And their comment was that the results of this study suggest that complete pain relief and return to activities after radial tunnel surgery is not as predictable as previous studies have indicated. And then Dean Saturianos decompressed 28 elbows to an anterior approach. He had 39% good or excellent results, and the remainder were fair or poor, and a significant percentage of the poor results were in workers' compensation patients. Posterior interosseous nerve syndrome is compression of the PIN, which innervates the ECRB, the supinator, ECU, EDC, EDQ, APL, EPL, EPB, and EIP. And generally, the causes of PIN compression can be a mass, either a lipoma or a ganglion. You can have elbow synovitis and rheumatoid arthritis, which puts pressure on the nerve, or repetitive activity, particularly involving pronation and supination. So there is no pain in the PIN syndrome, and the symptoms can either be a complete PIN palsy or partial PIN palsy. So in a complete palsy, you have loss of finger MP extension, loss of thumb extension and abduction, and you retain wrist extension radial deviation because the ECU is out and the ECRL is in, causing the radial deviation. Now, you can have a partial PIN palsy of any component of the PIN, and it may be specific to the medial branch, which is to the ECU, EDQ, and EDC, or the lateral branch, which supplies APL, EPB, EPL, and EIP. So the diagnosis is primarily made on physical examination and confirmed on EMG nerve conduction studies, which are usually positive in PIN syndrome. And you may need imaging in the form of MRI or ultrasound to rule out a space-occupying lesion. So the differential diagnosis can include cervical radiculopathy, which, however, is usually, it doesn't result in as specific deficit as PIN palsy, Parsonage-Turner syndrome, but the characteristic symptom at the beginning of presentation of Parsonage-Turner is pain, which is not present in PIN palsy, tendon rupture, and one of the ways you can distinguish tendon rupture from PIN palsy is the wrist tenodesis effect. And the other differential is radial sagittal band rupture with subluxation of the EDC, and there you can demonstrate that that's what the pathology is by straightening the finger, bringing the MP joint into extension, and then the patient is able to hold the MP joints extended under their own power. So if imaging shows a mass or a ganglion, early decompression and excision of the mass is indicated. If there is no mass, you want to observe the symptoms, perhaps consider steroid injection, but some of these do resolve. If there is no improvement by 3 months, you generally start thinking about decompression. Now, some authors talk about 3 months, some 6 months, but certainly by 6 months, you'd want to consider decompression. And the approach for decompression is as described for radial tunnel syndrome, the same surgical approaches. So this first series talked about 94% of patients, i.e. 16 of 17 patients, who had full recovery of motor function after decompression of the PIN by a mean of 4.5 months, and surgery was performed at an average of 2.2 months after the onset of symptoms. And the second series reported 75% good to excellent results at a mean of 5 years in 8 patients with PIN decompression at 4.5 months post the onset of symptoms. Finally, I'll talk briefly about Wartenberg's syndrome, which is compressive neuropathy of the superficial sensory branch of the radial nerve. So the superficial sensory branch of the radial nerve can be compressed anywhere along its course in the forearm, but it's most at risk at the posterior border of the brachioradialis and the interval between the brachioradialis and the ECRL muscles. So in pronation, the ECRL moves closer to the brachioradialis, compressing the superficial branch of the radial nerve between the muscles. And with wrist flexion and ulnar deviation, the nerve is stretched. So activities requiring pronation, wrist flexion, and ulnar deviation apply both a compressive and a shearing force to the nerve. So the symptoms are pain on the dorsoradial aspect of the distal third of the forearm, which radiates to the dorsum of the hand, thumb, index, and middle fingers. Clinical signs include Tinel sign over the superficial branch of the radial nerve in the interval between the brachioradialis and ECRL. And you can distinguish the pain from decurvains by the absence of provocative tests and the lack of relationship to wrist and thumb position. Electrodiagnostic studies may show decreased amplitude of the sensory nerve action potential and prolonged sensory latencies. So many of these resolve spontaneously, so the initial treatment should be observation and may include splinting and steroid injection if the symptoms persist. Surgical decompression includes incising the fascia between the brachioradialis and the ECRL from 6 to 8 centimeters proximal to the point of emergence of the nerve between the muscles, and distally to the insertion of the brachioradialis on the radius. And then you do a neurolysis of the superficial branch of the radial nerve. And this study by Lanzette and Fouché described 74% success in 23 patients treated for Wartenberg's syndrome. Thank you.